It's my pleasure to introduce Dr. Larry Jamieson, Executive Vice President of the University of Pennsylvania Health System and Dean of the Perelman School of Medicine. So, Dr. Jamieson.
And thanks so much for putting this program together. And as we transition from this scientific symposium to the panel, it's a privilege for me to think back on the founding of the Vassar Center in 2012. It's really hard to believe that it's only been 8 years. When you look at the amount of progress that's occurred, I think we've been able to see John and Mindy Gray's vision realized. The amount of public outreach, the dissemination of knowledge, the scientific foundations upon which we're basing the genetic counseling and emerging new clinical trials and treatments is really inspiring. And I know it's so meaningful to them, and also to Sherry and Len Potter for supporting this global prize. And it's just impressive for me to see how the world has been connected by the Vassar Center, and it's really terrific to see the inclusion of this fantastic science out of the University of Cambridge. COVID-19 has affected so many things in our lives. And it seems strange that we're holding this panel virtually, but perhaps the silver lining is that we may have more attendees than we ever have before. I know one of the goals of the Vassar Center has always been public outreach. There's also been a very sharp focus on disparities in access and information. And so, like we do in so many of our other areas in cancer and cardiovascular disease, this is a great example of how we can try to close some of those disparities gaps by disseminating information in different languages and very widely through this virtual medium. Susan, we're very fortunate to have you as the Vassar Professor of Oncology and Executive Director of the Vassar Center, but you seem to also have a second career now as a panel moderator. You do such a terrific job of engaging our panelists from around the world in interesting dialogue, debate, and generating new ideas. So we're very grateful for your leadership at the Vassar Center. It's now my privilege to introduce John and Mindy Gray, who will have a few words to say before we start this panel discussion.
Thank you, Dean Jamieson, for your beautiful introduction and, of course, for your leadership. And congratulations to Dr. Easton and Antoniou for your life's work. I am a Philly girl, born and bred, so I know how tough and resilient Philadelphia is. But nothing shows it more than the team at the Abramson Cancer Center, who simply couldn't be stopped by COVID. It is this commitment, this strength, this tireless focus, even under the most trying of circumstances, that is changing the treatment, prevention, awareness, and research landscape for BRCA-affected families. It is what gives John and me and so many others hope, even at this time when the world seems particularly tilted sideways. My sister Faith died at the age of 44 from BRCA-related ovarian cancer, and not a day goes by that I don't feel an empty spot in my heart. The Vassar Center stands here today to provide hope that other families never have to feel this gut-wrenching pain that we feel. The gut-wrenching pain that my nephew felt when, at the age of 4, his mom was taken away. So thank you to everyone listening. You are our cherished partners in this mission. To Dr. Larry Jamieson, John Epstein, Bob Underhyde, to Kevin Mahoney, and our intrepid leader, Susan Domchek, with Drs. Dripkin, Nathanson, and Greenberg right by her side. To Laura and Beth and so many others. Thank you to the researchers listening, the genetic counselors, the doctors, the nurses, the patient advocates, the donors, the friends. And for those of you who have lost a loved one, we feel your pain, and we promise we are not stopping until there are better outcomes and game-changing preventions. We know if anyone can make this a reality, it's the team at Vassar.
Thank you, Mindy. As she said, I just want to talk a little bit about the background on the Vassar Center. And as Mindy noted, that this all started with the loss of her sister and Sherry's sister, Faith, who was an amazing woman. And we at the time, like other BRCA-affected families, faced the dual challenge of dealing with a tragic loss of life, but then also processing the multi-generational impact of having a BRCA mutation in our family. We looked around for answers, and we saw some great research that was being done around the country, and as we saw today, around the world. But also, we said there was no central hub. There was no one place where we could find the answers we needed. So fortunately, we stumbled upon Susan Domchek and Penn Medicine through a Google search. They were intensely focused on BRCA mutations. They happened to be a mile away from the Vassar family home, and they were housed at our alma mater where Mindy and I met in romantic poetry class in 1992. So we decided to form a partnership with Penn Medicine to build that central hub. And that's what the Vassar Center is all about, working tirelessly to support BRCA-affected families with a team of genetic counselors, clinicians, and scientists. It's also about raising awareness and advising affected families. And of course, it's about accelerating research on treatment, early detection, and as Mindy said, someday finding a cure. Since we founded the Vassar Center in 2012, the progress has been remarkable with the advent of targeted treatments like PARP inhibitors and far greater understanding about the origins of BRCA-related cancers. All of us on this call are dedicated to continue this fight in some way, either on the front lines helping patients, searching for scientific answers, or as a family struggling with difficult choices. More than anything to me, the idea that women have to undergo prophylactic oophorectomies and double mastectomies is simply not acceptable. We must make more progress in the lab and translate it to patients as fast as possible. I want to, like Mindy, thank the medical and scientific professionals here for all the sacrifices you make in this fight and let you know, yes, we are with you 100%. Mindy and I have given now over $100 million to this cause, much of it to the Vassar Center, and also helped to raise with the help of many of you on this call, more than $50 million in addition. And we are not done. We encourage everyone here to help support this critically important struggle. It just means too much for too many families. The urgency is now. Before I hand things off to Susan, I want to also congratulate Drs. Easton and Antoniou for their Vassar Prize Awards, and also point out that we reward next generation's leaders in the field as well through the Pearl and Philip Vassar Innovation Award, named after Mindy and Sherry's beloved parents. This award provides researchers early in their careers with the resources to advance breakthrough science, publish findings, and go after larger grants. I'm proud to share the winner of this year's 2020 award is Penn Medicine's Kim Reese-Binder, an outstanding person and scientist. With that, I hand the mic over to our inimitable leader, Susan Domchek.
Well, thank you so much, John and Mindy. Thanks as always for your support, both financially, but more importantly, the commitment that you have and bring along with all others. Again, we are grateful for the Vassar Center and for all the support to be able to do this work and to collaborate with so many. I wanted to just direct people to, we do have resources on our website related to our Latinx initiative and our Black and BRCA initiative in terms of targeted resources. We do have Spanish-speaking materials as well. And Alejandra, by the way, everyone wants your video. We've got tons of comments in the chat about whether they can see it. So you can let us know at any point if we can post, how to share that video if that's possible. So again, we're really intent on dealing with issues of disparities, particularly at this time in our country, and we're going to be talking about that a lot more today as well. Before we begin, again, a little bit of housekeeping. We've had a ton of questions submitted. Keep submitting them on the question and answer function, and I'll try to keep track of everything. But now I'd like to introduce, I think all of you who attended the keynote know, Antonis Antoniou and Doug Easton from the University of Cambridge. We have Alejandra Hurtado de Mendoza, who's an assistant professor at Georgetown University, and Jacquelyn Powers, who's a senior genetic counselor at the Bassler Center. And so I'm going to just jump right in there. Doug, a question for you. Tell us what it's like to have gone from painfully cloning genes by Sanger sequencing to where we are today in terms of the technology related to genetics. Can you give us a sense of that?
Yeah, so there's a huge change, of course. I mean, 30 years ago, we didn't really have, there was no human genome sequence. That was obviously the biggest difference. So going from the location of a gene to finding it was, you needed a lot of tricks, and it was very painful. If you were setting out today to find BRCA1 and 2, probably a graduate student could do it in days, I should think. So the technology is just so much better now. Of course, the problems are harder now because we found BRCA1 and 2, and the other genes are harder to find. So you need to do bigger studies. But the technology advances have been enormous.
And could you say a word about the non-coding genome and what we might learn from that? And what do we mean by that?
Yeah, sure. I mean, that's still a big question. I mean, most of what's come out of the genome-wide association studies is really in the non-coding genome. So most of these risk-associated SNP variants, these common variants, they're not coding. They are in sequences which regulate genes, and that seems quite clear. So we have this kind of dichotomy that we have the risk genes like BRCA1 and 2 and CHEK2 and ATM and so forth, where you have coding variants. But most of the common variation is really in the non-coding genome. Now, how that works is a really a big unknown. I mean, we know now some of the target genes, but exactly how those variants influence risk is really that's a big unknown for the future.
And so, Antonis, you mentioned collaboration and the importance of prospective studies, but I want to push you a little bit more on that. Can you tell us the difference between retrospective and prospective studies, and how we can get in, how retrospective studies are useful, but how they can get us into trouble if we rely too heavily on them?
Sure, yeah. So I guess kind of it comes down to the epidemiological principles. So in a prospective study, we start usually with unaffected individuals, and we ascertain all the relevant information that we want to use for risk estimation, whether, for example, it's the mutation or a lifestyle or hormonal risk factor at the start of recruiting someone, so the unaffected, and then we follow them up over time to see whether to either estimate risks or to compare the risks in individuals with or without the risk factor. So on the other hand, in retrospective studies, what we do is we recruit the individuals after the events occur, so after the cancer occurs. And then we look back at what happens. So all the lifestyle hormonal risk factors, for example, are ascertained after the event. So those could potentially introduce some biases when it comes to how that information is collected. If there is differences in the way that affected versus the unaffected women report the various lifestyle hormonal risk factors, that can induce biases in the analysis. The other thing, when it comes to estimating risks, we may rely on self-reported cancer family history. So unless someone actually confirms the family history, it's likely to have inaccuracies. Whereas in a prospective setting, we just follow individuals and estimate the risks. I guess the other advantage is that we know in the case in particular of breast and prostate cancer, where the incidence has been changing over time, we know it has been increasing. In a retrospective study, we may be looking at what happened a very long time ago, whereas in a prospective setting, kind of these are more recent data, so the estimates that we get of the risks may be more relevant to the women that we see and the men that we see now in family clinics.
But it's just to give a sense for those on the call that the reason why you might hear different numbers at different times, it all depends on the study, depends on whether or how the patients were collected. We often talk about ascertainment bias that, for instance, in the study that Antonis showed where the patients were negative for mutations in BRCA1 and 2 in their families and don't seem to have an increased risk, the early studies showed that there was, and that was because those families that were coming in for testing had tons and tons of cancer. So that's why we just have to be careful about our study design, and it's why we have epidemiologists to keep us honest, because I am not one, and we are kept honest by it. But Jackie, we are seeing more and more now, especially in the US, and I'm sure in other places, individuals who come in with a BRCA1 or 2 mutation, but they have no family history of breast or ovarian cancer. So now they come to us and they say, do the risks apply to us? And how do I think about this? So can you talk to us from a counseling perspective, what that's like?
Yeah, it's challenging because, in the normal forum, you have individuals coming to you with BRCA1 and 2 positive results in the context of a personal or family history. When there's absent family history, there's a couple of questions. Is there really family history there for which is just not reported or known? But we're starting to better appreciate that there probably is more of a wider spectrum of risk. And so you're employing these high risk numbers and these prescribing provision of mammogram, MRI, considerations of surgery, when there is probably a certain percentage, though small, for which those indications might not be there. And so I think, it's a very challenging, complex topic or area. I also think folks who don't have a personal or family history, the mechanism by which these individuals are getting tested, is it through direct to consumer? Are they being informed? Do they know what they're essentially getting into? So there's a lot of shock and disbelief, testing positive for a BRCA1 or 2 mutation. If individuals are walking into this for fun or intellectual, just something to do, versus if the intent was really a concern for cancer risk. So I think psychologically or psychosocially, it's really challenging as well.
And Alejandra, you well articulated sort of the issues related to racial disparities in genetic testing. And one of the specific questions that was brought up in the comments was what you feel is the role of implicit bias from providers in terms of the discrepancy of testing. Can you comment on that?
Yes, I think implicit bias can definitely play a role in the providers not recommending or not referring minorities to genetic counseling and testing. We have seen striking disparities now with Latinas and African American women not having the discussions, and maybe 7 times more likely not to have discussions about counseling and testing. And I think part of what happens is that a lot of providers don't know that genetic testing costs have decreased a lot. We did a study in which we interviewed providers, including counselors, patient navigators, doctors, etc. And of course, counselors knew that testing cost wasn't such a big barrier anymore. But that information hasn't trickled down to all the providers. And sometimes the providers who attend minorities, there might be patient navigators, social workers, etc., or even primary care providers who don't have that information. And some of them are assuming that the minorities cannot afford the cost of genetic testing. So then they're not referring them to begin with to testing. So we have found that information both from the at-risk women telling us and also from the providers' perspectives. So I think it's important, in addition to the implicit bias, just assuming that if you're providing services to minorities, they're not going to be able to cover it, but also developing education interventions for providers so that they're more aware about these issues and how to refer. And there's already some of these education trainings, and one of them is family trees that I think I mentioned Dr. Graves and Dr. Baden-Parampil have, and this is to train community health workers about hereditary breast and ovarian cancer and how to refer women. And I think programs like this would be really important in addition to implicit bias workshops.
And Doug and Antonis are always amused when we talk about insurance issues because it's so different in the UK. And so the irony in the United States is that you can there are $250 tests not going through insurance, but that can cost you nothing going through insurance. But then sometimes you have a copay or deductible. It's a messy business that further complicates issues. So as we could anticipate, we have a ton of questions related to polygenic risk scores. So Doug, I'm going to ask you the first question, which is, we like to use acronyms. So we got GWAS, SNPs, PRS. Can you just take us through some basic education?
Sure. So thank you. So the first is SNP. So that SNP stands for single nucleotide polymorphism. So that's basically just a single letter change in the DNA sequence. And they're very common. There are millions of them. Most of them do nothing at all, but some are associated with risk or other phenotypes. PRS, that's polygenic risk score. So that's basically a way of combining the effect of many SNPs. So an individual SNP only changes your risk a little bit. But if you have hundreds of them, then you get a combined effect. And so you can identify people who have a lot of the risk variants of the SNP or few. And that's why you can use the polygenic risk scores in risk prediction, whereas an individual SNP wouldn't be very useful. GWAS. GWAS stands for Genome-Wide Association Studies, horrible acronym. So basically that's a way of studying a lot of SNPs across the whole genome. Rather than trying to guess and study just individual genes or positions, you can study 500,000 SNPs in one go. That's why it's genome-wide. And really that's the reason we've been able to identify such a lot of risk SNPs for all the common cancers is because of this GWAS technology.
Well, it's very helpful. And Antonis, there's a lot of questions about, how to use SNPs. So we talk about lifetime risk, residual lifetime risk, risk over 5 years, risk over 10 years. And how certain are we about all of those things right now related to these? Could you kind of comment on the different ways to look at risk information?
You mean the risk on the basis of these polygenic scores, or just on average in BRCA?
Apply it to polygenic risk scores for the fun of it for today.
In terms of the polygenic scores, I think we have large enough studies where the effect of the polygenic score per se seems to be quite precise. I think the issue that we haven't done yet is we haven't done large scale prospective studies in mutation carriers to assess this prospectively. We have some more studies that were published in the past few months. But I think we need these long-term studies to assess the risk prospectively, especially when it comes to combining these together with all the other risk factors and so on to provide more personalized cancer risks to mutation carriers. That's where the prospective studies will be really useful there. To have this long-term follow-up to assess more precisely whether the various combinations together can clearly identify women into different risk categories. So
to follow up on that a little bit, I think that the polygenic risk scores, if you will, and individualized SNPs, there's been much data on this, but how we combine these with other factors, how we combine it with family history or reproductive history, I think that those are things that are ongoing. So you've kind of alluded to that, but that's where prospective studies can give us a better sense. Would you say, in terms of the common factors?
We have a good handle on those, I think, on how they how they combine together. For example, data that are coming from BCAC and so on, they are showing that in the great majority appear to be acting multiplicatively. I guess what we want to be doing, and that's what we have been using in the risk models that we've developed. The issue is that we want to be assessing those in large-scale prospective studies as well to see whether those assumptions are valid or not.
And Doug, another great question was, do you envision that any of the SNPs could be targets for cancer prevention or treatment? So obviously, how do these relate?
So I think that's definitely, well, perhaps not the SNPs, but the genes that they target, I think, yes. I think that's quite likely. We have now hundreds of potential targets of these associations, so it's a whole new, area to explore. It took, what was it, 15, 20 years to go from finding BRCA1 and 2 to finding a treatment which was specific to it. So it's probably going to be a long process to actually going from SNP gene targets to therapies. But there's a lot of promise, but you need a lot of effort to really understand how they work, I think, and that's really much less understood.
And Alejandra, many of the SNPs and polygenic risk scores have been studied and validated in white populations. So Can you comment on that and how that can impact your work?
Yes. So most of these studies, as you mentioned, have been conducted with populations with European ancestry and East Asian, but not so much with populations of African ancestry, Hispanic, Latinos, indigenous populations. So the risk of that is that the findings might not generalize as well to all populations, and then those polygenic risk scores might not be as predictive in those populations. So it is really important to encourage participation in the studies from diverse populations.
Now, Jackie, we have a ton of questions about clinical application, and we're not going to be able to answer all of these in one go. One of the questions, many questions, were whether this information is clinically available. And I don't know what it's like in the United Kingdom. In the United States, to some degree, this is available. Jackie, do you want to comment more?
Yeah, there are a few commercial labs now offering polygenic risk scores. Those who are unaffected, and then there's also a specific lab who's doing polygenic risk scores in individuals who have personal or no history of prostate cancer. And so we are actually seeing in the clinics calculated PRSs in those who are mutation positive, but also mutation negative. And it's really challenging our practice because, we're a large referral center, so most of the individuals who are coming to us have inflated lifetime risks for breast cancer, oftentimes negative for mutations in high-risk genes. And so obviously, you are all on this call more versed in talking about PRS than I, and its limitations, but also its promise. And so how do you marry those two when you have a patient in front of you and you have to prescribe changes to care, and what is the actual risk? And it's really probably those top centile high riskers, but then also the folks that come to us who have are in the lowest centile, right? So they're now below general population risk and are even not going to offer, say, a breast MRI, for example. And so it's really, really challenging. I feel like the word of the day is challenging.
Yeah. The clinical implications, the implementation has been a little rough because again, if you have someone who has a very high cumulative lifetime risk based on a polygenic risk score in combination with her personal risk factors, and yet the family history is not one that we would normally be discussing preventative mastectomy, but now we have this number that is a challenge. There's obviously there are a great number of rising number of mastectomies done in the United States, including contralateral mastectomies in women with breast cancer with no specific genetic risk. So we're pretty sensitive to that issue. And likewise, if we don't do less with people who have lower polygenic risk scores, is it only ever something that we're going to do more with? What you want to do is risk stratify and do less to some people and more to some people. That's how it's valuable. So I think that we need to and we're working on it, but I think on the clinical end, you guys have done an amazing job, but now in the clinic, we're really trying to sort this out on the ground. There's another question for Doug and Antonis, whether you're implying that different SNPs and PRS could explain why someone gets a triple negative versus an ER positive breast cancer in the same family. That's very...
Yes, I think that is true to some extent. Yes, so the PRS are to some extent subtype specific. So there's some SNPs that are more ER negative, some are more ER positive. So you can sort of so to some extent that's true. We're not very good at that yet. So that's still very much work in progress. But yes, you can now in principle predict the risk separately based on subtype specific PRS, and probably more detailed than that too. I mean, that's still another areas. You may be able to go more deep in subtyping than just ER positive, ER negative, triple negative.
Antonis, one question that we get a lot in the clinic, and we have also before the conference and online, is people want to do things lifestyle-wise to impact their risk. And a lot of the things that we study, they're not really lifestyle. They're reproductive factors that one has some, but not a lot of control over, right? So certainly we don't have control over menarche. And it's hard to tell people that they should have a child at a certain age or how many, right? So that's not usually what we do. So how do we get, and can you talk as an epidemiologist why it's hard for us to look at lifestyle compared to a genetic risk factor, meaning people want to know specifics of their diet and things like that. How do we look at those more detailed lifestyle risk factors, and why is it so hard?
Well, I guess it comes down to the epidemiological study designs, that those are harder to study. They depend a lot on self-report, and if it's retrospective data, kind of all the possible recall biases and so on. So I mean, diet in particular is really tough. I don't think kind of we have been able to study that at all in BRCA1 and BRCA2, at least in the large consortia that we have been involved in. I guess one of the challenges that comes out of the analysis that are being done now is this, have some conflicting results, for example, compared to what we see the effects that is being in the general population. Of course, once you start taking into account the different tumor subtypes that are being developed in BRCA1 and versus BRCA2 carriers, for example, ER negative, so you get to explain some of these differences. But there are some still, I think, kind of, for example, oral contraceptive use. We still haven't got a good handle on the effect of oral contraceptives, whether it's related to the study designs that we have, the studies that are available so far, or we haven't got big enough studies to address those kind of. I think these are outstanding questions, I think.
It is worth noting that in the general population, lifestyle risk factors matter quite a bit, and exercise and weight matter. And Alejandra, I mean, this is an issue in many underrepresented minority populations, the issue of just generalized lifestyle factors. Do you want to say a word about that?
Yes. So there's also disparities in some of these health behaviors. So you have like lower physical activity levels among African American women, for example, higher obesity. So when we talk about like diet, physical activity, even breastfeeding, so those are important lifestyle factors that could be target of interventions. But also, again, thinking about the ecological model. No, there are a lot of factors that are influencing those behaviors, and it's not only individual, but it's also the neighborhood where people live. How much access do they have to secure spaces where they can do physical activity? How much access to fresh food? So I think we have to consider those in the context of like the social determinants of health. And I think the good thing is that in the populations and in my research experience, women are very keen on doing lifestyle types of interventions. So I think that's very positive. And I think like even though we're talking about genetics and hereditary cancers, also conveying the message that lifestyle is also important. So I think that's important for minorities too.
And important because the interventions we have, including early oophorectomy, can make many things, heart disease and issues of bone loss. So a healthy lifestyle is important one way or the other. We have a lot of PRS questions, so I'm going to go back again. Doug and Antonis, are PRS scores commercially available in the UK? Is that something that people get now, or is it still under research guise in the UK?
I think actually there might be a company that's offering them now, but generally speaking, they're not available other than through them. I mean, some of the companies that were mentioned earlier offer them. They would be available in the US and the UK as well, but the main thrust now is kind of translational studies. Look at so it's more in the translational research arena, and Antonis mentioned earlier some of these in his talk. Fortunately, I think, and I would worry about the commercial versions. I think it's going to happen, but you can get these wrong. You have to be very careful. This was mentioned earlier about the population, making sure that they're well calibrated and so forth. So, it's not. We have to tread a bit carefully, I think.
And that is an additional question asked by Judith Balmania. Thank you, Judith. Related to the minimal quality criteria to consider using in the clinic. So validation, discrimination, calibration. How will we be able to tell that we got all those things right? I think this is all the clinicians that are looking for you to say, yes, it's perfect, go for it.
Do you want to answer, Antonis?
Well, I can start, and maybe you can add whatever I missed. I guess kind of some of this, as I showed earlier in the presentation, we are starting to see some of the validation studies that we are doing, that they are providing encouraging results in terms of predicting the risk in different categories well and discriminating kind of adequately. Of course, kind of these are only a small number of studies. We need to do the studies in much larger populations in different contexts to see kind of if it's kind of related to if we should be using the models differently in a family clinic setting versus the population or that screening level. So all these needs, I think, kind of need to be done.
I'm going to follow up on that point about population versus a high risk population, because in some ways PRS scores may be more. I'm not saying they're not valuable in the population we're talking about, but they might be even more valuable for the average population, right? In terms of who should get screening, when they should start. Because if you will, all the people we're talking about, it may very well help in decisions, but in terms of the screening, not screening, when to start. So Doug, do you want to comment on that more, the general population usage of PRS scores?
Yes, I think you're right that in terms of the big picture, that's where the biggest gains will be. So, in most Western populations, breast cancer screening is typically sort of aged 50 to 70. Women with high PRS will reach similar risks at much younger ages, and there have been lots of studies coming out now that show that in principle, in terms of detection and false overdiagnosis and so forth, there could be potentially big gains at the population level by screening the higher PRS, women with a high PRS, more at a young age, and potentially less screening of the women at the low PRS. So there are different ways you could imagine, and it's probably quite dependent on the culture as to how you would actually implement that. But I think the general principle is clear. I suppose the other interesting question is that women at high risk, according to the PRS, would could also benefit from, for example, MRI screening, which is routine for BRCA1 and 2 carriers, would be more sensitive also for women in high risk based on the PRS. So I think my guess is that sooner or later that will happen. Potentially it must be a beneficial approach.
The implementation science has its place. We have to figure out now how to do it right in the right way. So Jackie, a lot questions also in advance of the conference about insurance coverage, and also whether or not currently in the U.S. any breast cancer patient has coverage, regardless of age or family history.
Yeah, so I would say we have criteria. Oftentimes women with breast cancer diagnosed at a particular age, quote unquote, early onset breast cancer, or in the context of a family history of breast ovarian, for example, would be eligible for genetic testing and thus likely covered by their insurance. What is not captured there is if an individual has a high deductible plan or unmet deductible, but across like all breast cancers, not necessarily. And so, if you're a postmenopausal woman with breast cancer at 65, absent family history, absent Ashkenazi Jewish ancestry, it's unlikely that submitting to insurance you're going to actually obtain coverage because there's a low utility or a low a priori chance of a mutation. In that context, individuals can be offered self-pay prices, and so the cost of testing has gone down dramatically. So no longer is it a $4,000, $2,000 test. It can be less than $300, in some respects $99 for BRCA1 and 2 only. And so there are self-pay options. In terms of kind of metastatic breast cancer or for utilization of like HER2 therapy, for example, there are certain labs that will not balance bills, so they'll cover genetic testing but won't balance bill the patient. So not covered by insurance, but an individual will not pay a lot out of pocket. So it's very nuanced and layered. But long story short, not everyone is covered, but there are certainly strategies to get those who need testing covered relatively adequately. Alejandra could probably speak to the underserved population and cost of testing. There are financial assistance programs as well. So even if you meet criteria, but it's still cost prohibitive, there are oftentimes a lot that the commercial labs can do to drive the price down.
Alejandra, any follow-up?
Yes, I was going to say that I definitely agree. In our population, the cost of testing hasn't been a barrier because the labs have assistance programs and most of our population qualifies. Like if you meet certain annual income criteria, which is pretty high for our population, then they offer the test at no cost or very low cost. So testing hasn't really been a barrier so much for our population, but it has been more the counseling. When you have populations that don't have insurance, covering counseling, it is much more difficult. So that's why we are seeing a lot of women being tested, but not having counseling. But we have also seen those women who receive like some negative results, but some even positive results, who don't really understand what happens. Sometimes they tell us, oh, I think I'm negative, but negative about what? Or even being positive without really understanding the implication. So I think that's something that we need to work for.
I did want to make a comment that there are a lot of questions and if you will, concerns that this panel may be being too cautious about PRS scores and that they're commercially available and that they can be ordered. Those things are true. They are commercially available and they can be ordered. We're sort of just, kind of going through the thoughts on it. Currently, again, there was a comment on whether we were talking about PRS testing or BRCA1 testing in terms of insurance. Most of these things are, if you will, kind of bundled with each other. So when, a test is ordered, so that's kind of a different issue. And so, again, these are commercially ordered tests that physicians can order if they wish to order them. And when we are considering ordering them, and we have some cases, by the way, later today reviewing this, we do sort of like to think about, what we would do with the information. So if someone is already qualifying for breast MRI, then sending if they're test negative for gene mutations, then would we not screen them if their PRS is low, for instance? So I think and that's why I think the general population may be a place where it's taken up a little bit more than the people we're seeing who are already, at high risk. So that's why the different implementation settings will be very interesting. I'm going to move into a little rapid fire session question because these are a bunch of questions that were asked in advance and are pretty straightforward. Jackie, if both parents have a BRCA mutation, does the risk for each child inheriting a mutation go up?
This is like not necessarily a rapid fire answer, but each parent respectively has a 50-50 chance of passing down the mutation. So that specific mutation, it's a straight up 50-50. But if you have two parents that are carriers, yes, simplistically, the chances of your child being a carrier does increase. There are a couple of nuances. Susan, I don't know how nuanced you want me to get. But in terms of an individual having a BRCA1 mutation, partner having a BRCA2 mutation, the likelihood of having a child to be a carrier of both or one or the other is about 3/4. Negative for both is 1/4. If you have two BRCA1 carrier parents, you do have a 1 in 4, 1/2 times 1/2 is 4th chance of having a quote-unquote double carrier. In rare instances, that does manifest in an infantile pediatric condition known as Fanconi. So if you're an adult and healthy, if your child is an adult and healthy or young and healthy, they do not have Fanconi. And rare exceptions, recognizing that those worlds can collide more frequently in those who are Ashkenazi. There are really no reports in the literature of the same BRCA1 or 2 respectively Ashkenazi mutation being passed down, one from mom, one from dad, into the end to have a child impacted by a double carrier. Those pregnancies are not usually viable. And so it's nuanced. If this has raised any concerns for you, the best thing to do is to reach out to a genetic counselor so you can work through your situation specifically, because it's very nuanced and contextual.
Yeah, as Jackie said, it depends if both parents have a BRCA1, both parents have a BRCA2, or one has BRCA1, one has BRCA2. And reproductive counseling is part of genetic counseling. So if that hasn't been explained to you, definitely feel free to ask us more questions. Another one, let's see. Antonis, you addressed this a little in your talk, but I'm going to have you re-say it. Are individuals who are negative for a known mutation, a known BRCA mutation in the family, okay, those true negatives, negative for a known mutation in the family, are they at increased risk for breast or ovarian cancer?
So I think if we take the evidence in as cumulative, what we have accumulated so far, I would say no, they are at much lower risk, close to the population risk. Some of the initial studies that were reported in the literature were retrospective studies. So, and those, going back to the study designs, I think kind of failed to address the issue of ascertainment, and that's where kind of they reported somewhat higher risks compared to the population. But most of the prospective studies, I think kind of all but 2 have suggested that the risks are close to the population, and those 2 I think have been really small.
Right.
I think the larger study has to embrace, kind of you cannot rule out really kind of modest increases, but even if you take the upper confidence interval of those point estimates, I think kind of you just start to get potentially into the moderate risk category. So I would say no, and there's a benefit in getting tested, kind of if you doing predictive testing in BRCA1 and BRCA families, because if someone is negative, then the risk is expected to be much lower.
So I'm going to take 2 questions really quickly. One is, what's the recommended age for genetic testing when there's a known mutation in the family, and why? For women in the United States, it's 25, because that's when, if you have a mutation in BRCA1 or 2, we start breast MRI screening then. For men, it's a little more complicated because it depends whether they're going to use the information for reproductive purposes. We don't do much in terms of their own screening to men until like 35 or 40. But for the women, it's definitely 25. We don't test children in the United States or anywhere right now because there's no evidence that knowledge of a BRCA1 or 2 mutation in childhood will impact your medical care. Another question was, can BRCA mutations skip a generation? No, they can't. If you have a mutation and your child did not inherit it from you, they cannot give it to their kids unless they inherit it from the other parents. I want to get now to a bigger picture issue, which is summarized by this quote. if you were a newly married BRCA1 cancer survivor planning to start a family, would you be comfortable having a child naturally, knowing the likelihood of passing down the gene is 50%? Are there going to be enough advances that for my future child, life will be different? So this kind of gets at, and dig deep here, like what's the future like, in terms of prevention and better options. And so any comments from you guys to start?
Well, I could make one comment perhaps is that, and this touched on a little bit earlier, I think the options for early detection are, I think that's a very promising area. So perhaps particularly for ovarian cancer, using blood-based markers. I think that's one area. I think another area which we haven't touched on much is imaging. I think predicting risk using imaging is for example, using mammograms or MRI. It's still a bit crude, but I think there's a lot of information available now that could improve that a lot. So I think those are two suggestions that might reduce the needs for risk-reducing surgery.
Yeah, and I would like to, there are a lot of different preventative trials that are planned or ongoing. At the Vassar Center, we're committed to prevention as a major part of this approach. We got approval by the FDA in March to start a preventative vaccine for healthy BRCA1 or 2 mutation carriers. As you can imagine, that was put on hold as vaccinating people to a novel preventative vaccine during a pandemic was felt to be best to wait. But we're trying to harvest the immune response, which we know in cancer matters, and to investigate immunology. There's a large international study coming out of Austria looking at a drug called denosumab, which is a bone strengthener medication to prevent BRCA-related cancers. And we're interested in the FDA for treatment, whether as we get to know more about their side effects, maybe we could use them for prevention too. There was also a lot of comments about the role of salpingectomy only, removal of the fallopian tube only, and leaving the ovaries in place. We're not going to have time to do that justice today in the remaining minutes, but there are multiple ongoing studies looking at that, which would be, does removal of the fallopian tube decrease the risk of ovarian cancer? And can you take out the fallopian tube and then later take out the ovaries? And again, Ronnie Dravkin at Penn has been very involved in this. There are multiple ongoing studies. And so we hope that will be a way to mitigate some of the negative effects of knowledge of this. If you could wait to take your ovaries out to closer to the time of natural menopause, obviously that would be a really terrific thing. The other theme is underutilization of testing. So both, and I'm going to give you 3 examples. Knowledge that having a BRCA1 or 2 mutation could impact your treatment. The fact that Ashkenazi Jewish individuals, 1 in 40, have a BRCA1 or 2 mutation and don't know it. And Alejandra, the fact that, we under test minorities. So how do we do better? I've opened it up to the panel of how we do better with all of that. Otherwise, I'll just talk, but I don't think anybody wants to hear me talk. So Alejandra, you go first.
Yes, so I think there's a lot of things we could do better to increase counseling and testing in minorities. And as I was mentioning before, these have different layers. So one is increasing awareness and knowledge. And to do that, you have to do it in a way that is culturally appropriate, which means having information in different languages. And I'm really glad about the Vassar Latinx initiative, because some of that information is not available. And also developing this kind of culturally targeted materials would be important. And oftentimes it's not only translating what already exists, you need to do much more in order to either develop new ones or develop a cultural adaptation. So it's not just translation. So I think in terms of education materials that can be developed, and then also tackling those system level barriers that we have seen in terms of low screening at community settings, so developing the infrastructure to increase the screening. Also, these workshops on implicit bias and patient-provider communication, as we have seen that there's suboptimal referrals and low communication about these issues. So I think it's like a multifaceted problem, and we need interventions that tackle multiple barriers, and I think implementation science can be really helpful.
And I want to just give a shout out for, point of care testing, which is something that the UK has really kind of pioneered, and we've been working on this. We were a little bit behind point of care testing because of our annoying insurance issues. In the UK, it's not such a barrier, but we and others have been doing a lot of work in this space where pre-test education, can be done by video or website or other formats, but at the same time, trying to incorporate counseling and not have people lost that have information that they don't understand on the other end. So I think that there's a great deal of work that's ongoing. So Doug and Antonis, what's the next great thing in genetics that's going to move us forward in terms of either a technology or an implementation strategy?
Yeah, I was dreading that question because predicting very difficult. I think in terms of the risk prediction, I think there are large whole genome sequencing studies coming on board, like the 100,000 Genomes projects, many similar projects. So I think that's potentially could be a game changer, but we're going to have to understand it's going to be a lot harder. So how to understand that data is going to be a big challenge. I think that's one area. As I mentioned before, I think imaging is going to make a big difference.
Antonis, any last comment?
I would go, I think, we really need to move towards the implementation studies because we've done significant advances. There have been significant advances. We really need to see now how we can implement them. Will women and men uptake all these novel developments, the feasibility and the acceptability of doing them in the clinic. So we really need this data to move, towards the implementation of all these findings in routine clinical practice, I think.
Well, great. This has been a fantastic discussion. I know we didn't get to everyone's questions, especially since some of them were on the chat. We will try to, as we've done in the past, we try to address them and answer them sort of on the Bastard website. So I wanted to thank all the panelists and for all of you attending this panel. And I'm going to introduce John Epstein, Penn Medicine's Chief Scientific Officer, for a final comment.
Susan, thank you so much. Thanks for leading a really fantastic panel, and thanks to all the distinguished panelists for your excellent comments. I learned a lot, and I appreciate the update. Speaking to our physicians and our scientists in the Bassler Center, it's clear to me that this field is moving quickly, and you can palpate the momentum. Thanks in particular to Len and Sherry Potter for supporting the Bassler Global Prize. Our recipients are well-deserved the recognition, and it was a pleasure to hear their keynote addresses today and to hear their participation in the panel as well. In their comments, both of them emphasized the large teams and the interactions within the country and outside of their own country that allowed their work to flourish. It reminds me that research, translation, and patient care is a team sport, and never has that been more evident to me than in the present COVID crisis. So many at every level have stared risk and hardship in the eye and placed the care of their patients first. It's obvious to all of us, I think, that cancer hasn't been on hold during the COVID pandemic. And the Bassler Center and all the many folks who support their work at every level, and the physicians in the Abramson Cancer Center have all responded with enormous selflessness and professionalism that I just have enormous respect for, and I wanted to recognize all of their efforts, especially in this difficult time today. John and Mindy, the Bassler Center is making a difference. it has become the model of how a center can coordinate communication and trigger new and innovative research across institutions and around the world. And we and others are trying to think of ways to emulate it in other domains. So its impact goes far beyond BRCA-related cancers. And you can sense how much it's making a difference by just looking back over the past year at the advances that have occurred. We've seen advances in the use of PARP inhibitors for treating pancreatic cancer patients who have BRCA mutations. You heard earlier Kim Rice-Binder mentioned, who's been spearheading some of this work. Susan Domchek has been leading efforts to study novel drug combinations to treat BRCA-related breast cancer, including PARP inhibitors with other agents. And the potentially truly disruptive approach of creating a vaccine against cancer has seen advances recently with the FDA approving the next stage of development, leading towards testing such a vaccine in patients with BRCA mutations who have not yet had cancer. And it's this type of real innovation that your support and your commitment have enabled. So personally, I want to thank you for those efforts. I'll just finish by saying that in my own experience, as a big research institution, we get a lot of support from the NIH and from other federal agencies that supports important work in many of the clinical trials that are ongoing. But much of the most innovative and truly differentiating work is allowed to go forward through philanthropic contributions. And the combination of the resources that the Vassar Center has been able to provide, combined with the commitment and drive and inspiration that the Grays and the Potters have provided, and the many other supporters to the Vassar Center, has inspired investigators to really come up with new approaches. And it's this combination that I think can be so very, very powerful. So I want to thank everybody for their support and the many people who've joined us today, the outstanding questions, and I want to hope all of you stay healthy and safe. Thank you very much.